All right, welcome. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for February 17th, 2022. Today's CME activity code is 484819. Got a great case today. It's Dr. Baxey's. I think it'll bring up a lot of discussion. There's some interesting surprises. Be a lot of fun. As usual, we have nothing to disclose, and the patient's anonymity has been very, very well hidden by changing a lot of the information. So that's really very important. The chat box is open, and put all your comments in there. We will open up the microphone as needed. Right now, the faculty has their microphone open, but we'll try to get to any comments that you might have. I think there will be a fair amount today. And I think this is being recorded and it'll be available on YouTube shortly. We're a little bit behind, but we'll get them all up eventually. And if anybody's not on our mailing list, let us know. We'll be glad to send you one. And if you need any more information about how to get CME credit, just email us and we'll let you know as well. So Pravir, you want to take over?
Yep. And the patient here is a 45-year-old, a Black woman who presented to us in clinic for evaluation of AKI and bilateral lower extremity edema. She had a history of type 2 diabetes, and on questioning, this had been diagnosed about 4 years ago, never on insulin. And her hypertensive history was for about 10 years, and she was on lisinopril in addition to hydrochlorothiazide and metoprolol. 3 months prior to coming to our clinic, she was diagnosed with hypothyroidism and started on a low dose of a Synthroid. 1 month later, she started noticing sudden onset of lower extremity swelling. And this persisted for weeks. It was bilateral, never happened before. And because it didn't go away, she went to go see her primary care doctor. She didn't have any other new changes in her medications. She wasn't taking any non-steroidals, no other over-the-counter supplements, etc. She had a little bit of mild dyspnea on exertion that was also new, but really no other systemic complaints. She had blood work drawn at that time that showed a creatinine of 1.8 and an albumin of 1.8 as well. Her creatinine was 0.7 just 6 months prior to this presentation. At that point, she was referred to cardiology given her swelling and dyspnea, and she had a TTE done for concern of congestive heart failure. That TTE was really unremarkable, had a normal EF. She had her labs done 2 weeks later that showed her creatinine was still elevated, now at 1.7. Her albumin was stable at 1.8. At that point, urinalysis was collected and showed 4+ protein, trace blood, 4 RBCs, and a urine protein creatinine ratio was sent off, and that was at 10 grams per gram. Her last UPC ratio was 6 months ago, and that was 0.3. At this point, she was urgently referred to our office for evaluation. She showed me pictures of her legs, and it was quite significant how much it was as in comparison to just months ago when she really didn't have any of this. She said it was maybe a little better, but really not much to the point where she could actually tell. She didn't have any gross hematuria, no rashes. And again, I asked her for anything that she was taking, and she said nothing else that was new in terms of her medications, either prescribed or non-prescribed. We got some labs, and ultimately a kidney biopsy was done. I went over her past medical history already, nothing else. The only other things I would add is that she had a GERD, and she was intermittently on a PPI, not taking every day. She did have a UTI history, and this was recurrent when she was a child, but none recently. And her only major surgical history was an excision of uterine fibroids. Social history, nothing to note of. She had had a family history of thyroid disease and diabetes, hypertension, but no kidney disease, no allergies. Her medications listed: lisinopril 20 milligrams, hydrochlorothiazide 25 milligrams daily. She was on metoprolol 100. She was on Genumet for her diabetes, multivitamins, Synthroid, and then the pantoprazole 40 milligrams, again, as needed, not every day. Exam, her vitals, blood pressure was 160 over 100. Her pulse was 80. She was afebrile. Her BMI was 36.8. On exam, she looked very comfortable, not in any distress, appeared her stated age. I didn't hear any crackles or wheezes on her exam. She had no significant cardiovascular findings, but she did have this 2+ lower extremity edema up to her shins bilaterally. No rashes, no other joint issues at all. Labs that were collected right before the biopsy, her Sodium was 138, potassium 3.7, chloride 103, bicarb 25, B120, creatinine was 1.7, glucose 85. Her total protein was 6.1 with the albumin of 1.8, calcium 8.6. Her LFT functions were all normal. Function panel was normal. Cholesterol was 320, triglycerides 260, and LDL 220. CBC, her white count was 8.8 with a normal diff. Her hemoglobin was 12.5, MCV 72, and platelets at 385. Serological workup I was able to obtain. Her ANA was negative. She had a positive atypical p-ANCA with a titer of 1 to 40. Her MPO and PR3 were negative, however. C3, C4 were both normal. SPEP and UPEP did not show any evidence of a monoclonal protein. Her kappa lambda ratio was 1.7. Her ESR was elevated, and her CRP was normal. Her UA, as I mentioned previously, was similar. pH was 6.0, 4 plus protein, trace blood, 4 RBCs, 3 WBCs. Her UPC ratio during this visit was up to 13 grams per gram. And her urinary albumin was greater than 600, which just means that we couldn't calculate a ratio because it was above the limits of quantification. So it was extremely high and likely primarily albuminuria in terms of her protein composition. Ultrasound was done, kidney were both normal in size. There was a little increased echogenicity noted bilaterally, but no hydronephrosis, the TTE that I mentioned before, and a kidney biopsy was performed.
Great. Dr. Rubin had asked about a TSH. Do you have a TSH?
Yeah, the TSH repeat after starting on Synthroid was back in the normal range, so it was controlled.
And another person was asking about her menstrual period, the timing. Do you know?
Her menstrual, she wasn't on her menstrual period at the time of the urine collection. It's a good question.
Okay. All right. Any other questions for Dr. Baxi?
I see a PLA2R antibody was not collected at this point.
How about thyroglobulin antibodies?
Say that again, I'm sorry?
Thyroglobulin antibodies?
No, I didn't have those.
Hashimoto's
Those
thyroid?
weren't done. No,
Okay.
those weren't done.
And then COVID status, did she have a COVID, either antibodies or infection or anything like that?
No COVID, concern for COVID, everything negative.
All right, Steve, this is in your wheelhouse. You want to start us off?
Not really, but I will. Yeah, we've got a 45-year-old, Black female with basically relatively sudden onset nephrotic syndrome with some renal insufficiency. And this history of hypertension and diabetes and pretty much a negative serologic, actually a negative serologic workup. I mean, the first thing that came to my mind, believe it or not, is that this is diabetic nephropathy. I didn't actually ask whether there's evidence of retinopathy, and you may have said something and I missed it, but there doesn't have to be, but if there was, that'd make it an even stronger argument for possible diabetic nephropathy. The whole idea is she's had diabetes for 4 years. In the adult onset diabetes, oftentimes they probably had diabetes for poor glucose control for a lot longer than just the time that they remember. So I think there's going to be diabetic renal disease here no matter what. That's my first, I guess, diagnosis, if you will. And then the question is that all there is? Is there something more? And then the something more is kind of the usual suspects: membranous, minimal change disease, and focal sclerosis, and at least for me, as the ones that stand out. I was asking about thyroglobulin antibodies because with Hashimoto's, you can get a membranous GN. They have antibodies to thyroglobulin and can sometimes have a membranous lesion. In an African-American female, I'd be remiss not to bring up FSGS for sure. I mean, I think that's a possibility. The suddenness of this whole thing, though, keeps making me wonder that she's feeling that she's probably got minimal change disease or FSGS with a tip lesion, or potentially more likely than not, a collapsing lesion. Could there be something more unusual? I guess there's really no evidence, and she's just on the cusp of thinking about a paraprotein related abnormality, but all of that's negative. I'm going to go with FSGS, collapsing lesion with background diabetic nephropathy.
You had mentioned earlier about diabetic nephropathy because onset's unreliable. Do you think just 6 months ago her serum creatinine was 0.7? Do you think she could progress that quickly?
Well, she could have acute renal failure on, I mean, we've seen diabetics who have significant proteinuria without, an elevated creatinine. I think that, there may be underlying acute tubular injury, either from her nephrosis, because her albumin is less than 2. So there may be another reason for her acute renal, or her renal insufficiency, if you will.
Yeah.
If that's what you're getting at, as opposed to being chronic, this may be more acute.
Pravir, do we have her? We had a creatinine 6 months ago. Do you know what her dipstick showed, or her? You might have said, I forgot.
No. She had dipstick proteinuria. No, she had the UPC ratio of 0.3, as I mentioned, and she had a dipstick proteinuria.
So that's all I need is
about a year before. She's had low grade kind of.
Okay, so that's really what I'm getting at. I mean, she could have AKI, but do you think she could go from a dipstick of 0.3 to something that's unmeasurable in a year, Steve?
Like I said, I think she's going to have background diabetic renal disease, and I'm putting a secondary lesion on top of it. We've seen stranger things have happened. We've seen patients that come in with this kind of very sudden onset nephrotic syndrome, and you biopsy them, and they have, nothing other than diabetic nephropathy. But I agree with you. You usually expect it to be kind of more indolent and progressive, if you will, as opposed to such a sudden type of switch from a low grade to nephrotic syndrome of this level. That's why I say there's more likely than not, I'm guessing there's a secondary lesion, and that's where I was bringing FSGS with a collapsing lesion, or, if she were white, I'd say a tip lesion, but Black patients can have tip lesions too, but the money is better for a collapsing lesion. So I thought I had said that there's background diabetes with a secondary lesion on top of it.
Yeah, I just wanted to make that point. And with Dr. Glassick, I didn't pay him to say exactly what I just said in the chat box. So thanks, Dick. Bill, what do you think? What about lupus, Bill?
Yeah, this comes up quite a bit in a diabetic, when to biopsy, right? We always think that the real answer to that is always if you think you're going to find something other than diabetic nephropathy or diabetic kidney disease. And when do we think that, a faster progression, a faster onset of proteinuria, we consider it if there's a little hematuria, that can be seen in diabetic nephropathy in about 10 to 15% of the time. And so, she's got a lot here that makes me think there's something either additional, as Steve had said, or independent of diabetic kidney disease. Pretty rapid onset in the setting of thyroid antibodies. I like the membranous idea. I would also, because of that too, put lupus there. We've got possibly an autoimmune thyroiditis. We've got a young Black woman who has a sudden onset of nephrotic syndrome. Would I be happier if the ANA was negative, or we had double-strand DNA or complement? Sure, but especially even lupus membranous, we see is often serologically quiescent. So it doesn't sway me away from having lupus here at all. And then I think the other ones are still really in there. The collapsing FSGS is a nice idea because you've got the renal failure with the nephrosis. Membranous with this degree of nephrosis could do that too. Could it be something a little bit more unusual, like an amyloid or an MPGN or something? I guess that's there, but there's nothing really that points to that in this case. So I'd really kind of stick to lupus and FSGS as my top two that we're going to see.
In what order?
Ooh, it's a good question. Why don't I, just because Steve said FSGS, I'll go with lupus, and we'll arm wrestle it out to the very end.
Yeah, you might as well go to the extreme.
And if it is lupus, I'll guess that it's a lupus membranous, and we'll see some foot process effacement and podocytopathy with it just for fun.
Yeah, Pravir just put in the chat the anti-double strand DNA was negative. It was less than 1 negative, but as we all know, with class 5 lupus, you can have any combination of serologies to minimal or even negative serologies. We sometimes call that latent lupus or whatever. But I just brought it up because of the demographics, and it's hard to ignore. But
there's some other serology that we don't have. We don't have an HIV. We don't have COVID serology. So this collapsing FSGS could be related to one of those secondary causes as well. So, and we don't always get the serology. I'm not saying that Dr. Baxi was negligent. I'm just saying that we don't always have them at the time of the biopsy.
Yeah, sometimes we don't have, sometimes it's left out, and that's really up to Pravir and what he presents. And I think we try to present as much as we can what we have when we do the biopsy, so it makes it a better discussion. Because if we knew everything beforehand, we might not even do it. So sometimes some of this stuff is done after the biopsy, and we can help us make a diagnosis. So we end up with what we call a pattern of injury, and then we have to put it all together. So. Mario, you had mentioned something about amyloid, and then somebody came back in the chat and said, well, too young, and you said no. You want to elaborate on your amyloid, Dr. Rubin?
Well, amyloid is always in the differential of somebody that presents with full-blown nephrotic syndrome. And the technology available through Mayo of laser microdissection followed by mass spectrometry has identified so many newer genetic variants of amyloid that we didn't know about in previous years that, we think about obviously AA, AL in the elderly, although AL has been described in younger individuals. As I mentioned before, I always remember the discussion at ASN of transthyretin by Steve, and so forth. So I think it's always a consideration to keep in mind.
Great. Dr. Glassick, before we spin the wheel, what do you think this case is going to be?
Well, perhaps I'm overemphasizing this hypothyroidism, which seems to track in the families and may be a sign of an HLA related disease. And certainly membranous is more related to HLA than either FSGS or minimal change disease. I'm concerned about the acuteness of the onset, but I don't think there's anything in this story that rules out the possibility of a membranous nephropathy. And of course, we don't have anti-PLA2R antibody. I would have to list membranous nephropathy pretty high up on my list.
Anybody else want to throw anything else in there?
Well, I raised my hand, Roger, because
sorry.
interestingly, recently there was a paper, I think by a Chinese group, about the development of membranous in association with checkpoint inhibitors induced thyroiditis leading to hypothyroidism. So I think that's an area that we need to remember. And there is an excellent paper, particularly for young trainees, written by Jeff Burns in CJASN about hypothyroidism and kidney disease, which is a must read.
Terrific. Well, I think it's time for the wheel. Set up here.
We also saw a SED rate that was high, and there was an atypical ANCA, and sometimes you could get fooled into thinking, or maybe in this case, I'm the fool for not mentioning it, but into thinking there's a vasculitis. But usually the atypical ANCAs are MPO or PR3 positive, and the SED rate can just be high due to the nephrosis itself. So that doesn't really make me steer towards vasculitis in this case. There's not that much hematuria. We're not really thinking nephritic, so I don't really think it's playing a role, but who knows?
Yeah, it's a good point. I mean, Dr. Glassick has brought up the fact that we pretty much should ignore the ANCA titer and really just rely totally on the MPO and PR3 because of because of the false negatives or false positives, excuse me. So we still report them. I think I still look at it, but I think it's probably he's probably right. We should just look at the specific antibody because you get fooled too much with the pattern itself. All right, wheel time. We only have one first-year fellow. The other two are off this week, so we'll see if
If it falls on you, Chinta, that's just bad news. Corbett.
Dr. Corbett.
Jeez.
We'll see if it is your wheelhouse or not.
Yeah. I'll give you 1 second. I'll give you control here.
Really? You won't turn off my mic?
Not today. And plus Casey's not here.
Yeah, good point.
All right, give me a second.
Do I have to click?
Not yet. I will let
All
you know when you can. Go ahead and click. Go, yep, and you can advance the slides in the bottom left there.
Got it small. All right. Let me do so we've got a trichrome, which definitely shows evidence of increased blue staining material in both of these cores with looks like interstitial fibrosis and some tubular atrophy. David, are you there?
Yes, I'm here.
All right. So, I mean, this looks like well over 50%.
Yeah.
I mean,
I
there are
agree.
only islands of what look like normal tubules to me.
Yeah.
And the rest of it, I mean, so I'm looking at more like 75%.
Yeah. Yeah. That's what I estimated. Yep.
Okay, good start so far here. And it looks like he's got some abnormal vessels here, or she has some abnormal vessels here as well. So we'll go to another, get to a higher power.
Yeah.
So here we go with an H&E. Again, more of the same. A lot of interstitial fibrosis and atrophy. I mean, this is a low power. Boy, it looks like way too many nuclei in here between the tubules. And I don't know if that's just because of, glomerular obsolescence. I assume this is a glom that's completely sclerotic. We'll probably see it higher power.
Yeah.
I'm assuming these are.
Steve, you're right though. There's the inflammation is too dense just for obsolescent glomeruli, and it's throughout the entire core.
Yeah, these like? Is this like again? We may have a higher power microcystic dilatation here.
No, those are just some residual tubules of normal size. The other ones surrounding are all atrophic and scarred.
Okay, so it's not like thyroidization or anything else. Is this? Well, again, maybe higher for it's hard for me to tell if these are tubules or if this.
Yeah, those two there are mildly dilated. It looks like with some intraluminal debris.
So I only really see one, maybe two gloms, one hanging off the edge here. Yeah, I'll go higher. Yeah, I mean, there's, oh my God, a lot of interstitial infiltrate, if you will, interstitial nephritis. Again, we don't have any glomeruli to look at to see if this is disproportionate to the glomerular scarring at this point, but there is definitely a lot of interstitial nephritis. It's hard for me to tell at this power, what the cells are, but we'll go on. Unless there's something more to point out here, David, I'm going to go on.
Yeah, no, this was diffuse and dense.
Here we've got a globally sclerotic glom. Again, tubular atrophy, interstitial nephritis.
And then in the center, there we have a higher power. Yeah.
Now this I can get. It's like the E on the eye chart here. We've got eosinophils all over the place.
Yeah.
The patient was on a PPI, right, Pravir?
Yeah,
Or am
PPI. Yep.
They did? They were?
Yeah, taking it intermittently, not every day, but was taking intermittent pantoprazole.
Okay. So we definitely see an eosinophilic interstitial nephritis on this particular photograph. What is all this yellow stuff, David?
I don't know. That just appeared.
Yeah, just give me 1 second, Steve. I just have to.
Oh, okay. I thought David had highlighted something off the screen, and I.
Give me a second here.
I'm thinking I missed
There we go.
something. All right.
And I'll give you back control. Go ahead.
All right.
Click. Yep.
Yep. So we've got big time interstitial nephritis. Well, here we go. So here's a glom that looks actually quite normal. And I'll assume we'll see more like this, which then gets back to this whole issue of the disproportionality of the interstitial disease relative to the glomerular disease. But this glom to me looks quite good.
Yeah, and it's kind of an island in the surrounding interstitiums, all fibrotic, and the tubules are scarred. Yeah.
there's a lot of pinkish material here.
Yeah, I think that's so if you go to the top right, I think you're getting on the side of a vessel. I think that's the media of a vessel.
All
smooth
right.
vessel.
Fair enough.
Yeah.
Is this the, I'll go back, sorry. So we have a segmental scar here. It's hard for me to tell where it is relative to where the hilum might be. This might be the hilum here, but there's definitely appears to be a segmental scar here. I don't know if this is a synechiae as well.
Yeah, right.
I mean, this glom clearly doesn't look normal. The capillary walls around some of this area, and this may not be a good one to look at because it's scarring down. It looked a little abnormal, but definitely a segmental scar with some hyalinosis.
Yep.
Now we have
Yeah, so actually
4
15,
gloms.
yeah, 15 gloms had segmental scars. So I put a little collage together.
Yeah, it's kind of like Woodstock when they used to have the 4 different things going on at one time.
Yeah.
For those that remember when that was 1970, or well, it was 69, but I think the movie came out in 70. So this looks like
this is Crosby, Stills, Nash and Young right there.
exactly. This looks like a peripheral segmental scar to me. I mean, it looks like it's scarring down at least some. Here we have another segmental scar that's out here. This almost looks a little ischemic the way it's collapsed down.
Yeah.
Again, I mean, we've got 4 segmental scars. And again, a couple of these look somewhat ischemic as well. So, there's definitely a segmental sclerosis going on for whatever reason. What we don't see is a nodular diabetic glomerulopathy. So I was way off on that. Well, we don't even see really any mesangial glomerular sclerosis to consider diabetes as a background. And then again, the tubular atrophy.
We still may see some background on EM, so that's not out of the question.
Or fluorescence, you're right.
Or fluorescence, yeah, good point. And what about, you'd mentioned collapsing as maybe your number one. Do these look collapsed to you except the one on the top left?
No, I mean, by collapse here, I mean the whole glom is collapsed. I don't see any epithelial cell proliferation, visceral epithelial cell proliferation that would make me think of a segmental or even a global collapse. I mean, here there might be a little bit, but nothing like I would have expected. These look pretty good, actually.
So are you kind of thinking NOS?
Yeah, well, I mean, by exclusion, right? I mean, I don't think, I mean, some of these, like this looks, it's hard to know where the hilum is. So I don't, the earlier one looked like it might have been perihilar. This to me looks like it could have been, but I just don't know. And you're right, by exclusion, it's going to be an NOS. It's definitely not a tip lesion at this point. Pardon?
Steve, just because our audience is quite large, can you just say what NOS is and for everybody?
Not otherwise specified.
Meaning? That
it basically is the otherwise classic scar that doesn't fall into the other categories, perihilar, cellular, tip, or collapsing.
Thank you.
Testing me out there on the acronyms. Damn it, I apologize. The indicator on the left keeps blinking in and out. So the silver stain looks pretty pristine. Actually, this is one of the best looking glomeruli, I think, other than one of the first ones we saw in the biopsy. All the capillary loops are open. I mean, there's a little epithelial cell activity, here, but they're just prominent. They don't look, there's no collapse. I don't see any holes. I don't see anything that I would call a spike because we could still have a membranous lesion here somewhere hiding, like a CHERD1, if you will, but I don't see it here. This looks pretty good to me in essence.
How do you feel about, well, never mind.
I feel like the IgG is going to be negative.
Yeah, that's just a ghostly outline. I turned up the background so you could see there was a glom there. It wasn't pseudolinear or anything.
Yeah, so it gets back to the thing that Roger brought up. But I mean, we'll see what the glomerular basement membranes look like, but there is definitely no pseudolinear staining to make us think of diabetes. I have to admit, the other thing that was in the back of my mind that we never brought up, which is always kind of way out in left field, was whether or not this person would have immunotactoid or fibrillary GN, but it's it's far less common in African Americans than in whites. So this pretty much takes out any immune complex mediated disease that we had talked about. Excuse me, for sure, membranous gets knocked out of the box, as well as, like I say, any other immune complex related disease that could lead to segmental scars. Interesting. So C3 is positive in kind of in a segmental nature, and I don't know if this is just in one of these one of these areas of segmental scarring.
You hit the nail on the head. It's kind of rare to get these segmental scars on the fluorescence, but this one had so many. Yeah, we did get a segmental scar, and the C3 and IgM are trapped.
Okay, I was going to say usually you see IgM with it, and that's why I was thinking there's something else going on here. I'm kind of trying to wait for this to come up so I can. Did I go too far? Was there another fluorescence?
No, that was it.
That's good.
So the IgM was segmental as well?
Yeah.
Okay, good. So I was going to say that the IgM will not infrequently get trapped as well, which does not go along with IgM nephropathy per se that some people talk about. And here we've got an electron micrograph. Here's nice loop. I assume this is an endothelial cell here.
Yep.
And the podocytes look great. At least for my eyes, this is a little low, but they still look like they're pretty nicely. They don't look like they're diffusely fused together, if you will. There's this schmutz in here in the lumen, but I don't see any deposits, not surprisingly. What I'm most surprised about, unless I'm missing something, is this doesn't seem to be as effaced as I would have expected it to be. On the other hand, there's this one, and this appears almost completely effaced. Here it looks pretty good. Here it looks good. Here it's a little more difficult to tell. Here it looks a little more effaced.
Yeah, it was just focal effacement. Just that one loop there in the center had the effacement, as you see. But
less than 80%.
Oh yeah, and the whole EM sample was only about 10%. Yeah,
Mario, I agree with you. I think that's where we're headed here. It's just amazing though of how to explain the level of proteinuria. Here we have, some focal. Well, here it's a little more diffuse. Here it's still spotty even here. I think this is a higher power of the one we were looking at because they're looking at this area here. This was just a higher of the one of the first ones we saw, higher of the first loop. So the diagnosis, well, I'm not going to be able to tell you what's causing it, but it looks like doesn't look like we have. Let me say this another way. What we have here is segmental sclerosis with focal foot process effacement. It's not immune complex mediated, and there's an intense diffuse, if you will, interstitial nephritis, both acute and chronic, that's eosinophilic in nature.
yeah, I agree with all that.
So how do you put that together? How do you put together that proteinuria with 10% foot process effacement?
That's a great question. It kind of knocks Bill's theory out of the water, right? There are, and I know Dr. Glassick will pull this one right out of the air, but I know I have read there are settings where, despite not having diffuse effacement, you can have significant proteinuria due to other membrane abnormalities. And don't ask me what they are, but I know I've read that. We don't see it that often, but I'd have to kind of go back to there's some other mechanism here, but clearly this looks like, with the exception of, the lesion itself with this focal effacement looks like a secondary form of FSGS. Secondary what, I don't know. But yeah, I cannot explain why there's such massive proteinuria. And, you know, this isn't like a secondary FSGS that we talk about where you've got nephrotic range proteinuria and the serum albumin's normal. This lady's albumin's on the floor. So I don't have a good answer as to how to put this together just yet, unless there's some other rabbit that's going to get pulled out of the hat here that I haven't thought about.
Bill?
Yeah, I think this is the like I put in the chat there, that this is really the tricky one, because when it, you know, especially when you're getting down to treatment, because your clinical presentation was consistent with a primary FSGS, but on biopsy, it wasn't really consistent there. So I think this is a conundrum. I think this is a tough clinical and treatment dilemma. I think actually it won't be, because there's the interstitial nephritis there, but we can get to that when we talk about treatment.
Yeah, the question is, what do you think's causing it?
Yeah,
I don't have an answer either.
Yeah, for the nephrotic syndrome, I mean, there are focal scars there, but you know, it shouldn't be that nephrotic in the absence of foot process effacement. So, but I do know that it's possibly it's a timing thing. Maybe the foot processes are in the development stage of becoming effaced, or the opposite. Maybe they're in the therapeutic phase of you know, becoming intact. And I think it's hard to say. What's causing interstitial nephritis is probably a little bit easier. I mean, she's on a PPI. I would go through her med list again and talk to her about herbal medication and all that kind of stuff. And I think because of that, the treatment becomes a little bit easier, as long as you think there's enough viability of renal tissue here, which was another little trick. But I think her clinical presentation dictates that.
Steve, what would you treat her with?
Well, I agree. I mean, I think the easy thing is she's got this interstitial nephritis. The question is how much of it's reversible. You know, I have a hard time justifying giving her steroids just for that FSGS lesion, given the fact she's only got focal effacement. And so, I mean, I guess what I'd be treating more would be the acute interstitial nephritis. And I guess hope against hope that maybe it'll have a positive impact on whatever's causing her proteinuria. But I think the easy thing to treat or deal with, relatively easy, is the stopping the PPI and whatever else you can find that she might be on that could be causing an eosinophilic interstitial nephritis, and giving her a course of steroids, if you will. Again, primarily focused at the interstitial disease. I have a hard time, other than just empirically using it, hoping that, you know, seeing if there's any effect. I have a hard time using it based on what we see with regard to the segmental lesion and the epithelials, focal foot process effacement. I don't have a lot of optimism that it'll have much impact on that. For sure, I'm sorry, for sure. And I don't remember enough. I would maximize the ACE that she's on and to see whether that has any, I mean, it's hard for me to believe this is all a result of some hemodynamic effect, but I guess
I think a little bit further workup, possibly getting a Natera screen that will at least give you her ApoL1 status. This is in classic for ApoL1 kidney disease, which doesn't have that much proteinuria, but I think that'd be interesting. They may pick up a genetic cause of FSGS too, which might lend you towards not treating as long or not, you know, but I think at least starting with what Steve said is also a good idea. I'd probably put her on 6 or, you know, a mg per kg of prednisone to do the interstitial nephritis and hope that it treated the FSGS too. But I think there's case reports of clinical presentations responding even without diffuse foot process effacement. So again, I'm not sure the mechanism, but
just as an aside, ApoL, I mean, I think the ApoL would be interesting to know as well. But the response to therapy is not dependent upon ApoL. And Jeffrey Kopp had a paper years ago that interestingly enough, for whatever reason, that the presence of ApoL1 did not dictate who responded and who didn't. So the people with ApoL1 responded as well to steroids or therapy.
So what about the possibility that this is you know, the real problem here is the degree of nephrotic syndrome with
preserved FPE.
Yeah, with the preserved, you know, minimal foot process effacement. What if she had a mild secondary FSGS and it's just all the interstitial nephritis that's preventing, you know, so she's not really that glomerular proteinuria, but the interstitial nephritis is preventing her from reabsorbing. And so the proteinuria is exaggerated by the tubular interstitial disease. Steve, you're shaking your head. Talk to me.
Yeah, I mean, I'd like to believe that. I mean, these people that have problems with whatever the tubulin, you know, but I wouldn't have, if that's the case, I wouldn't expect her albumin to be so low.
So basically, yeah, but hardly this much is what you're saying.
Yeah.
Yeah, I think that's a fair point. Dick, I mean, what do you think about this? What do you think about somebody who has 9 grams of proteinuria and 10% foot process effacement with segmental scars?
Yeah, I'm as puzzled as everybody else is, but this case kind of reminds me of Hickham's dictum. Every patient has the right to have more than one disease. And I think, as Steve has pointed out, you do have an eosinophilic interstitial nephritis, and that might be treatable, and it might be related to the drugs that she's taking. So what harm would be done by giving her a short course of steroids? Her diabetes is under good control, and I don't think that that would be a problem. This is not diabetic nephropathy, for sure. No basement membrane thickening, no mesangial expansion, no hyaline arterial sclerosis. This has got nothing to do with her diabetes. Because of the disparity between the nephrotic syndrome and the foot process effacement, I would seriously be thinking about doing genetic testing. I just have an intuition here that there's something behind all this that we don't understand, and pulling out the genetic testing bag is something that can often bring forth something we didn't expect.
Great. Well, that's good. I think let's move on to Pravir. You can tell us a little bit about your thoughts about the case. Pravir.
Yeah, absolutely. And I'll give some updates, in terms of some of the other labs. The PLA2 our antibody was negative. So not that we saw anything on the biopsy, but just to complete that. But yeah, this is kind of where we are at final pathology. And this is what we had. This patient has, she FSGS, but, the biggest surprise there was the foot process effacement, also the degree of interstitial fibrosis and tubular atrophy. Again, 6 months prior to this, her creatinine was 0.7. And her diabetes, as I mentioned in the chat, her hemoglobin A1C was controlled. It was less than 7%. And so, I still thought I couldn't put together what caused this acute onset. And I went back and she showed me pictures, and it wasn't one of those instances where the swelling has been going on for months to years, and now, it pops up. This was within, a 3-month period. And so, again, this is just to show the final pathology, the report from the biopsy. So the clinical questions I had for the patient were really these 3 things for me. How do I explain the sudden onset of nephrotic syndrome? And it makes me feel a little better that, the people on here have also at a loss of explanations as I was when I got the report. What's the cause of the interstitial nephritis? I think that was a little easier for me. And I think, the PPI and plus minus the thiazides, I think the PPI more likely, but, those 2 things were on her medication list. She was taking the thiazide daily, and she was taking the pantoprazole every so often, not daily, but PRN. And then finally, with everything, what do I do? Do I treat do I treat steroids? Where do I go from here? So ultimately, as people mentioned, and just briefly, I think the onset of this, the clinical presentation for this patient is kind of classic for, what I would have thought to have seen is a primary FSGS kind of findings with diffuse foot process effacement of greater than 80%. Because she presented with clinically, again, with hypoalbuminemia with her sudden onset. She had 13 grams of proteinuria, and that was primarily albuminuria. And but again, her biopsy was more consistent with more of what we would typically clinically correlate with a secondary FSGS with very focal to minimal foot process effacement. But the genetic part is interesting, that you can have you can have variable foot process effacement in these patients. And I guess, the biggest thing there would be, treatment for genetic FSGS with steroids or any of the other immunosuppressive medications aren't really advantageous. They don't really work as well as a primary FSGS, where you could do steroids, or if steroid resistant, you can go to CNIs, etc. So what did I do? Well, my thought process was, as people mentioned, was that at least there's acute interstitial nephritis. And I know she had 75% fibrosis, but, she's young, she's 45. And, I said, let's give it a shot. I know she had diabetes, her BMI is elevated, but I started on prednisone 60 based on her weight. I not doing 80, but I did 60, and I put her on PJP prophylaxis. I increased her lisinopril to 40 milligrams. She was on 20 milligrams daily. And I stopped her hydrochlorothiazide and PPI. And I did another thorough review of her list of medications, and none of those she wasn't really taking anything else. So from here, I think we have a poll.
So we have a poll.
Yeah.
Here's the question. So he gave steroids, and what would you expect? A, no decrease in proteinuria. B, moderate decrease in proteinuria. Or the third option is marked decrease in proteinuria. And basically we're saying the second option is that secondary FSGS and ACEs and ARBs and RAS inhibition will decrease the proteinuria. The third option is that we think steroids will actually treat this lesion. And the first is that nothing's going to happen. So we're kind of directing it towards a therapy-based outcome, based on what you think it is. If it's a primary podocytopathy that might respond to steroids, or are we just going to treat this hemodynamically with RAS inhibition? So we'll give it a few more seconds.
Pretty good response so far, almost 85%.
What about the
Yeah.
possibility if you improve her renal function, her proteinuria will actually get worse?
That's a good point.
All right, if you think that is, then you can call Steve on his cell phone later. I'll hand out the number. Okay,
Here's the results.
So is it up?
Yep.
Yeah, okay, so yeah, 10% said no decrease in proteinuria, 60% said a moderate decrease in proteinuria, and about 30% thought you'd actually get a marked decrease in proteinuria. Interesting. A little surprised that option 3 was as popular as it was, but just an opinion. So Praveer, you want to tell us?
Yeah. Need the drum roll. So this is actually what happened. So I put her on 80 milligrams of prednisone, as I mentioned, and the timeline here is about 8 weeks. This is her urine protein creatinine ratio. It was 10, and it had gone 13 at the biopsy. At that point, the next one was down to just above 8. And what happened here was that she really did start having issues with the steroids, which would not be totally unexpected. She had weight gain, her diabetes and her hyperglycemia was harder to control, and she just did not like it at all and was having issues with it. So at that point, she had still less than 50% reduction in the proteinuria if you look at this. And so at that point, after 8 weeks, which would be a little longer than I would have done for acute interstitial nephritis, because you'll see on the next slide the creatinine was not improving. And so I kind of said, okay, let's taper it off and we'll kind of go from there. And this is what happened over the next 4 months as I was tapering off her steroids. And we went relatively faster than I would typically. Her proteinuria just kept on coming down, and it kept on decreasing down to now less than 2 grams. And this is about now only 6 months after her biopsy, and she's off steroids. And so again, I was concerned now, okay, if there was something I had treated in terms of her primary FSGS with steroids, would this now relapse and get kind of worse, and you'd see that increase again? But now this is over a longer interval. This is now 2 years later, and her proteinuria continues to remain less than 2 grams. It's really around 1 gram now, and hasn't gone back up there. And the other part of this would be the creatinine. The creatinine here was 1.7, and you can see it kind of did decrease a little, but it really never improved back down her baseline, which was 0.7 just 3 months prior to the biopsy. Now, over the course of the last 2 years, it's gone up a little. Now it's closer to 2.5, but her albumin here was 1.7. It did go up along with the decrease in proteinuria, and it actually normalized. And right now her albumin is above 3.5. And this is 2-year follow-up. I have not seen any change or worsening her proteinuria. Her creatinine has been stable now. At least this is over the last year or so, around 2.5. And her diabetes is back controlled with with her medications. She's still on the list of about 40. Her blood pressure is controlled, and of course she's not taking the PPI anymore. But this is kind of where we were. I still think it's interesting to, I can't really explain, what this sudden improvement was, but I would have to say something happened here with the steroids. And I think, the points of genetic testing is a good point. I think that is interesting just to kind of put together, but I still don't see how it completely fits into really what happened for her course here with the steroids. But I'll open it up to see what people's thoughts are or comments or.
How many weeks did she just get? 8 weeks of prednisone?
8 weeks of high dose.
And then you were tapering her off over the next?
Yeah, because she just wasn't doing well on it.
Yeah, I mean, that's impressive how rapidly she responds to it. I mean, I'm starting to go back to what Bill was saying, is maybe we were catching this on the down curve in the sense of her proteinuria had picked up, things were starting to get better, and we were seeing, the podocytes improving, and it's, who knows? I mean, I don't disagree with that treating at all. I mean, but whether this was actually just her automatically getting better independent of the steroids.
Mm-hmm.
Yeah, the question would be, if she didn't have interstitial nephritis, what % of people would have given her steroids?
No, that's a great question.
And I don't know. It's, of course I would have here because I saw the response, but beforehand, I don't know. It acts 100% like primary FSGS, acute onset, very nephrotic, high cholesterol, very low albumin. And then you see 10% foot process effacement. I think it'd be hard not to maybe give it a try and just assume that it's, but 10% foot process effacement, that's not what we consider primary FSGS. I will point out, we brought this case out today because we had a couple years follow-up, and it's such a remarkable case. And back then we didn't have genetic testing available, we didn't have APOL1 testing available, and COVID wasn't in the picture back then. So we can't tell you everything at the beginning, but it doesn't change this remarkable story. And I don't know how to put it together, other than, I don't know actually how to put it together. I'm just glad that she did get steroids and she got better. The irony is that I think everybody would have predicted the creatinine would get better from the interstitial nephritis. The proteinuria would change a little bit, and it was the exact opposite.
That's why I wonder whether, that's why I threw the viral thing out there. I've seen, I mean, usually it's more collapsing FSGS, but I've seen patients, who have had a viral-like illness come in, have FSGS, usually more often collapsing, and then like out of the blue get better faster than you can imagine. And some of them have gotten steroids and others haven't. Actually, there was a case I got that was from California. I think Cynthia Nast had seen the patient, was the pathologist. And when I saw the person and I saw the biopsy report, and he said he'd had collapsing FSGS, and everything was essentially normal. I'm like, I couldn't believe it. But the only thing I could think of was maybe some of these people, whether it's parvovirus or another virus, have some acute viral process that then resolves relatively quickly.
And that was brought up in the chat box too. It's a really good point. When we see collapsing FSGS, we think of these viruses. Do we know, Steve, much about non-collapsing FSGS with viruses?
I mean, I think you can see it. It doesn't always, I mean, I think it's just like everything else. It's more commonly seen that way. Same thing with genetics. Some of these people with genetic forms of hereditary forms are collapsing, but not all of them. I think the bigger issue is if you really thought there may be something genetic going on here, but if you thought this was a genetic form of FSGS, I mean, almost by definition, they're steroid resistant. I mean, period. And so this is almost contrary to that. Like I say, whether this is a response to steroids or just, it was getting better on its own, and we gave steroids, and the two kind of coexisted. And so this is considered a treatment success. Who knows? I'm sure we've all had a lot of those. The steroids probably made no difference. It was something else that was getting better on its own. But at the end of the day, who cares, right? I think we do bring up. I'm sorry. I just think the point you bring up, though, is a good one. I think many of us, in somebody this nephrotic without the interstitial nephritis, would probably say, why not just give it a shot and see? Because as you say, from my perspective, she's really young. I was kind of laughing when Prevere says she's young when she's older than Prevere is, but but yeah, I mean, you want to give everybody the benefit of the doubt, and not everything matches up like you would hope it would. I think if she'd had a lot more glomerular scarring, and if, I mean, what is interesting, I'll stop talking, but it is interesting that David, you know, what we saw, at least on the biopsy initially, which must be patchy, to have 75+% interstitial fibrosis and then have her go into a remission like this, at least from a proteinuria standpoint, I find amazing.
So in the chat, somebody said, maybe need to change our classic thinking that secondary FSGS doesn't present as full-blown nephrotic syndrome, or that maybe we should be treated. I think you still, you know, you still have your
These are
general
outliers.
rules. Yeah, this is still an outlier. But I think the key here is that, you know, do you completely give up just because of 10% foot process effacement? No, and that's not what doctors do. Doctors make decisions based on the big picture, and I think Prevere did a great job. Dick, have you ever seen anything quite like this?
Well, I can't recall seeing a case exactly like this, because this case has the superimposition of an acute hypersensitivity interstitial nephritis, probably due to drugs. So this is not a pure case. And I think everybody who has been entered into this discussion has forgot about the fourth category of FSGS, FSGS-U, undetermined cause. Remember, that was in the paper by Fervenza. It's been in all of the categorization, including the KDIGO, has primary, secondary, genetic, and U. This patient falls into the U category. And we don't know very much about the natural history of that group of patients. Saying this patient is getting better, I think, is a misnomer. She continues to lose nephrons, despite the fact that her proteinuria has declined to under 2 grams per day. She's had a very massive reduction in proteinuria, yet she continues to lose nephrons, not due to diabetes, probably not due to the inflammatory influence of interstitial nephritis, but something else, and we don't know what it is.
And I think that's a really good point. But I would suspect if the nephrotic part of this disease didn't go away, that she'd be on dialysis already. So I think that, yes, she's progressing, but she still had a remarkable response, and probably avoided a lot of the complications of her nephrotic syndrome as well.
One of the other last things, and I know you want to wrap it up, but you know, this whole issue of the secondary FSGS due to associated with perihilar lesions and obesity and androgens, not androgens, but obesity and reduced nephron mass, et cetera. I think, you know, the beauty of this that Prevere brought out very nicely was that this person, and everyone's discussed it as well, went from 0 to 100 with regard to proteinuria in a very short period of time. You don't usually see that with these other these adaptive forms of secondary FSGS. It's usually more indolent, developing into a nephrotic range proteinuria. They're usually not they're not hypoalbuminemic. I think that's the really unique thing about this, with the association of this focal effacement, which I think gets you back to the whole issue of sometimes I guess you have to throw something out and decide, well, this acute presentation may warrant giving her treatment independent of the interstitial nephritis, and just throw out the focal effacement. If she would have had a progressive indolent chronic course with progressive scarring and reduced nephron, or reduced renal function and normal albumin, and yet nephrotic range proteinuria, then we might be having a different discussion about steroids short of the interstitial nephritis.
Yeah, and it keeps coming up in the chat, genetic studies for, 3 or 4 different good reasons. I think they're all good reasons, even if it doesn't change anything. So I think
APOL1 may be an important factor in this when it gets back to what Dr. Glassick is saying, is there may be some underlying mechanism here that's predisposing her, like APOL1 and the hypertension is the second hit, independent of the proteinuria.
I like the viral story, but it doesn't really matter. We're not going to be sure. But I think that's still, if you still have contact with her, I think it'd be a good idea. you might find nothing, but you never know what you're going to find until you look. And I think that's a really good idea. And I know that the lab we send to will look for Potosin, et cetera, abnormalities as well as APOL ones, high risk genotypes. So I think that's a really good idea. In the end, I mean, 10 grams of proteinuria with 10% foot press effacement. I don't know how we're going to ever put that one together, but it had maybe a better ending than we thought, and certainly brought up a really great discussion. So I want to thank it. We're going to wrap this up. Thanks everybody for joining us. Thanks Praveer for a great discussion and resurrecting what was really a great case. We're going to do a few more of these resurrections where we have a long-term follow-up, so we can. Because a lot of times we end these cases with, well, we'll see what happens, and sometimes it's as interesting what happens as to what got us there. So we'll keep an eye on your email. We will probably be back next week. Everybody, until then, stay safe and take care.